friends, one day one judge went to a dentist and he had taken Gita with him. And he asked the dentist to put the hand on Gita and said, "You shall remove the tooth, the whole tooth and nothing but the tooth." I'm asked, I sometimes, Rahul? Where is Rahul? Yeah, there. And Ankur. When I showed this program to my wife and told her proudly that I'm a patron, so he said that I think it's a male-dominated society and there is a gender bias. Is there a matron in your society or no? I said, there is no matron. Matron is not necessarily chief of the nurses. A distinguished person and lady with an objectivity and maturity also is known as matron. So I would suggest that, Rahul, next time when you organize a trip, have one matron also. Well, I think first of all, when we call main branch and side branch, I think you are automatically giving a diminutive importance to circumflex artery, which I think is very wrong. The reason for that is very simple. Because in 90% of the cases, or more than 95, circumflex artery supplies more than 10% of myocardium. And this is therefore should not be called as side branch. And as rightly put by somebody else, other before me, is that main branch 1 and main branch 2. And not only that, but because when you have a myocardial destruction or myocardium at jeopardy or myocardium at ischemia, more than 10%, the revascularization has a far superior outcome over a period of time, and hazard ratio is in favor of revascularization. So when we talk of one stent strategy and get away with 2 strategies, we should not keep in mind that you are not having an approach of grapes are sour. No, that should be careful. There are 4 main trials which have influenced your thought process and your technique. It has influenced also your thinking and your ultimate strategy in the cath lab. Excel and Noble. Tell you, surgery or PCR? I think in the morning I've seen very complicated cases, and nowhere I think all these cases could have been. First of all, I want to ask you, is there any single trial where they have shown that surgery is inferior to angioplasty? Not a single one. Surgery is not inferior to angioplasty. It's same thing like thrombolysis and palming. And wherever, show me a single trial where at any point of time, within 1 hour, within 4 hours, within 24 hours, thrombolysis is superior to palming, usually non-inferior. And therefore, we are also be satisfied that we are non-inferior to surgery, but never superior to surgery. All right, never mind. When the analysis takes place and randomization takes place, it is a case is taken when both surgeon should say that I can do it, and the physician should say that I can do the angioplasty also. And then is included in randomization. 90% of the time, the rejection is by the physician, not by surgeon. A lot more things he can do, which we cannot do. So therefore, this must be kept in mind. So what I'm trying to say, the threshold for an appropriate case to go for surgery should be a little low. Our patient-oriented approach should be towards that in case if the surgery is likely to be safer and superior, we should not hesitate to offer surgery to patients. It's a good form of surgery. 7 days in 7 days of difficulties or hospitalization in an ICU stay is a great investment many a times. All right. Now, EB, Excel, and Noble. Now, let us see. Noble trial. They were at variance. Noble trial clearly showed that angioplasty is inferior. Although I must say that all these trials in Excel and Noble, death was almost identical. There is a caveat, not always, but there is a caveat. And the Noble trial showed that it was inferior because MACCA, MACE, was much higher in DES, and that was driven primarily due to increased number of myocardial infarction and need for repeat revascularization. Fair enough. On the other hand, Excel trial selected those kinds of cases where the syntax score was below 32. And it showed that the primary endpoint with fluoropolymer coated everolimus eluting cobalt chromium stent, namely Zions, had identical results practically, provided the complexity of the case is low. And therefore, this was followed over 5 years. Incidentally, I must share with you that the incidence of myocardial infarction was differently made. It was, the definition was once not a universal definition, but SKY definition. And you all know, you've read it, that leading to that, the surgery members resigned from the Committee of Excel. Moreover, we must also know that the Zion stent and the entire trial was funded by Abbott. So this is important to keep in mind. And it showed that if you take a less complex case, and what do you mean by less complex case? Syntax score. But syntax score is purely anatomy. Is the syntax score purely defined on anatomy, and that too angiographic eyeball viewing, which is now very heavily criticized, that apparently a flow limiting obstruction and angiography might not be flow limiting, and vice versa. A simple lesion might be seriously flow limiting. So we have to have a serious doubts about the thing. Moreover, we must also keep in attention the what kind of cases have been selected. For example, in Excel, the syntax score up to 22, more than 32, no. On top of it, in Noble trial, 2 or 3 non-complex lesions were exclusion, total exclusion. Dr. Davidson's case, which I saw, the circumflex artery was fully, the RCA was totally occluded. Of course, we might have been very well collateralized, as I can see, etc., but those kinds of cases. So therefore, when you have taken a case on your cath lab, you must make sure that the case is adequately represented to any of the arms of Excel or Noble trial before you apply the criteria of Excel or Noble. If your case is falling outside the selection criteria defined by Excel or Noble, then that case is off-label as far as these 2 trials are concerned. Very important to keep it in mind. All right, let us say Excel was very meticulously done. Repeat revascularization. By the way, in Excel trial, the death, MI, and stroke, repeat revascularization was not included in MACE. But of course, when later on it was included and reanalyzed, it was found that repeat revascularization was far more common in the PCI arm as compared to surgery arm. Is the repeat revascularization merely a sequelae? Is it a sequelae or is it a serious matter? Read David Holmes' paper, Too Much Smoke Under the Fire, which says repeat revascularization sometimes cannot be very benign. And especially you know very well that there is a repeat revascularization needed in a drug-eluting stent. What options you all have? What do you do? And the repeat revascularization is also not uncommon and is a very big bugbear. All right? All evidence is level now, and therefore it has been upgraded to a level of evidence A in cases of a simple or a moderately complex left main bifurcation. Both in Noble and Excel trial, the distal bifurcation was in 80% of the cases. And what is the definition of a distal bifurcation? 70% or above. Now, are we always sure that apparently 70% looking is also a flow limiting obstruction? They have also added, yes, if it is between 50 and 70, then it should be supported additionally by a provocative ischemia as judged by a non-invasive method. Well, I still have a lot of things to talk about the criticism about these 2 trials, Noble and Excel, but time would not permit, so I would not go ahead. So quickly go to the complex. Now, Dr. Colombo once very openly said, and I totally agree with him, at any point of time where you are handling a left main case, and if you felt for a second that this guy is going to need 2 stents, believe me, it is going to need 2 stents. And there, if you have a distal bifurcation of 80% and in distal bifurcation of a severe distal bifurcation stenosis in 80% of the cases, and when we know that the circumflex is supplying more than 10% of myocardium in 95% of cases, how will you be avoiding circumflex case? How will you be able? Is it common into clinical practice that you can get away by putting 1 stent? Hildig Smith told once openly that how do you want to prejudge the outcome of a circumflex before putting the main branch stent? Maybe after putting the main branch stent, the circumflex is totally unaffected. Maybe, but what happens when it is affected? Serious matter. And when the side branch is a complex lesion, that means the lesion length is more than 10, and then the plaque burden is more than 50%, it is considered as a complex lesion. And there's, of course, I think the side branch should be always stented first. Now, I would skip now. This is a very important slide. 47% of the patients who were treated in DK Cross provisional arm, DK Cross provisional arm, 47% needed a second stent. Now, if every alternate patient is going to need a second stent in the provisional arm of a DK Cross trial, what kind of provisionality? Every second patient is going to require a second stent. I might as well finish the case by putting the side branch stent first and then do this. Now, they said, now Goran Stenkovic, in my personal communication, said that when he was trying to recruit the center all over the world, when he went to England, there were only 6 centers which were capable of doing DK Cross. Criteria of DK Cross in China, when it is included, Chen included, what was the kind of registration, the centers which were registered? Those who have done at least 200 angioplasties per year and more than 20 left main every time. Very stringent criteria. It was done by those experts who knew how to do DK Cross. Well, if there is a paucity, I know that very well, that what is a prerogative of an expert will not be able to see daylight for a very long period. Fair enough, there are certain cases in which the circumflex is hardly involved. There you can get away by putting a stent across the circumflex artery by a provisional stenting, and maybe, and Davidson clearly showed here that if the second, and also I think everybody in the morning showed that if the side branch access up putting in the main branch stent is very difficult, then I think it is better to put the side branch stent for to secure it if you think it needs to be secured. I'm talking of those where the side branch also needs to be addressed otherwise. All right, fine. Now, 9%, where I think, by the way, 42% of the cases were only subjected to the imaging in both Nobel as well as in Excel trial, only 42%. And I think the outcome could have been different was it used for a more number of cases. I don't know. This is the algorithm. If the lesion is simple, how do you, all right. If the lesion is simple and the side branch access is easy and the provisional stenting is done, you can study the side branch by Bonvan Koo has done, that 75% of the cases which show that the side branch is 75% stenosed has an FFR of more than 80. Fair enough. After putting a main branch stent, if the FFR is 80 and above, I'm happy. And that benefit is sustained for 5 years because he showed the data. Who showed the data that the side branch has an FFR of 80 at the end of your procedure by putting a main branch stent first. In provisional strategy, then the side branch can continue to stay well. I agree. But what if the side branch is complex? And the definition of complex we already discussed. Then I think you should put. Incidentally, in the EBC main, when there was a tube stent technology arm, Culotte, provisional, TAP, and T were maximum used. In the two stent arm of EBC main, DK Cross was used only in 5% of the cases. Now you all people are talking all the time in the morning that DK Cross is a much better technique to do a bifurcation, left main bifurcation. Then if it's done only in 5% of the cases, obviously the two stent arm is going to show an inferior result. All right. Now DK Cross 5, cardiac death, MI, CD, TLR 12 months, 5% mess rate in the DK Cross stenting, provisional stenting 10%. All right. Side branch pre-dilatation in 39% of the cases due to side branch compromise after main vessel decision. This is, I'm showing provisional arm in DK Cross. Provisional arm in DK Cross. The side branch pre-dilatation in 39% of the cases resulted in compromise after the main vessel dilatation. 47% required additional stent in the provisional arm due to suboptimal result, out of which 38 simple, 64% complex. And most important, failure to deliver second stent in 9% of the cases. So at least the 9% will go back home with incomplete treatment. So ladies and gentlemen, Keep in mind, this is ABC main. There are only 2 seconds left, so I'll go straight away to conclusion. Lots of complicated cases has been shown, but I'm not interested to show a very complex case. Nevertheless, I think we always show successful complicated cases. Failed complicated cases are always on the shell run to this, our cath lab shelves, no problem. And finally, in conclusion, I would say that left main lesions with distal bifurcation, 80% of the PCI is a suitable option with additional moderate complexity. That means syntax score should be less than 32. Whether single stent or 2 stents should be decided on complexities in the approach to the side branch, which was illustrated very well in the morning. Side branch should be clinically significant, supplying more than 10% of the myocardium. If the side branch lesion is complex, better to address the side branch first. In 2-stent technology, DK cross seems to be way superior to all other techniques shown in DK cross 1, 2, 3, 4, and DK cross 5. And now we're going to get DK cross 7, which will be, I think, IVUS guided and FFR guided. Thank you very much.